Thanks a lot, Larry, and thank you, Omer, for inviting me. Thanks to the AIM Foundation for organizing this today. I'm very pleased here to talk to you about immune therapy with T cells for melanoma. We'll just go ahead. As Larry pointed out, it's an exciting time for melanoma research, and we wish people never got melanoma, but if you're going to have melanoma, much better to get it today than 5 years ago or 10 years ago when we had very little in our toolbox. We now have a lot more in our toolbox to treat melanoma. It's very exciting, and I totally agree that new drugs are coming out so rapidly that if we can get someone through at least a couple of years, who knows what's going to be available 2 years from now. And so we're very optimistic about the therapy for melanoma, more than we ever have been in the past. So the reason it's important to find therapies for melanoma is that it starts on the skin, many times related to sun exposure, but not always. There are kinds of melanoma, like mucosal melanoma, that it isn't related to sun exposure at all. But the issue with melanoma, why it's so deadly, is at any time it can spread almost any part of the body. And so caught early, we can cut it out, but the problem is it can spread. So we need to really come up with therapies that can go throughout the body to treat melanoma. There are two main classes that you're going to hear about today: targeted therapies that turn off the light switches of the circuitry of the tumors, and that you'll hear some nice talks about today. The other kind is immunotherapies, therapies to stimulate the immune system. And I'm going to talk about one of those, T-cell therapies. You'll also hear about the anti-PD-1 and other therapies that stimulate the immune system. Ultimately, we're going to want to put these therapies together. So the T-cell therapy can be summed up very simply. Whether you talk about T-cells or vaccines or anti-PD-1, Yervoy, all these drugs, the goal is one thing: kill cancer cells. So with a cell called a T-cell. So if you look at the T-cell, if you consider the T-cell like the batter and the tumor, the ball, that's simply it. The T-cell touches the tumor. They can do what's called the kiss of death. It releases enzymes to poke holes into that tumor, so the tumor then shrivels up and dies, and the T-cell goes on to the other tumor and does the same thing. So I'm going to try to see if I can start it from here. Let me see. If not, can you please put the pointer on that black square and push enter, and then that'll start that. Great. So this is the T-cell, and this is a tumor cell. It's just time-lapse photography. You can see the T-cell kisses the tumor and releases enzymes to poke holes in the tumor, and then it can just travel on to the next tumor cell, travel on to the next tumor cell, travel on to the next tumor cell. So any immune therapy we do, all we're trying to do is kill tumor cells with a cell called a T-cell. This is a T-cell. We evolved these T-cells so we could kill viruses in the body. That's why we evolved, but now we're kind of using it to kill tumor cells. So that's the overall goal. The kind of therapy I'm going to talk about in this talk, though, is actually growing these T-cells to large numbers outside the body. In every melanoma, the immune system's trying to kill the tumor, but obviously not doing a good enough job because the tumor is growing. So we've learned over the years to take the tumor out of the body, to chop it up into little pieces, put it into the laboratory, and add a drug called interleukin-2, which induces the proliferation of immune cells. And so after about 4 to 6 weeks, we have huge numbers of T cells, and we can give patients, we then expand them 1,000-fold, and we give patients up to the order, we just treated someone with 150 billion T cells last week, and then we give them along with their growth factor interleukin-2. So that's pretty much the therapy. Before that, we give a little chemotherapy to dampen down the normal T cells, but that's pretty much the therapy. It's a 2 to 3 week inpatient admission for that. 1 week to get the chemo, 1 week to get the T cells and IL-2, and then 1 week to kind of recover. But after that, the therapy is done. You come back for one more cycle of IL-2, and then that's it. And we've seen some very nice responses in some patients. This is a patient of ours that just graduated from college and came to see us. Had a very painful mass here, had lesions in her lung and her belly, and then all the disease went away, and after that, she's just back to living a normal life. I think she moved to Alaska for a while. It was hard to get her scans, though, because she was all over the country. But she didn't need any other therapy after that, because these immune cells can stay and live in the body for a very long period of time, years, in fact. Here's one of our patients. He worked in the oil industry, and he had a number of therapies, including chemotherapies, then had a large mass. We tried surgery multiple times, but the tumor kept coming back. So we finally gave him T-cells. And now it's actually been over 3 years, and he continues to be disease-free. Our overall response rate is 45%. That's how many, out of the patients we treat, how many patients have tumor that shrunk. And some of these therapies are highly durable, as we talked about, over 3 years. We have some patients out to 4 years now. I think that's because the immune cells can live in the body for a long time. If you think about your vaccines, you get a vaccine. When was the last time you got your polio vaccine? It was probably when you were 4 years old, but you never had to get it again. You still haven't gotten polio. It's because our immune cells have memory and can stick around. And so that we've detected these immune cells 4 or 5 years later of the cells we gave. They can stay in the body. We're finding that the more cells we give, the better. We've been monitoring our progress, and if patients get more cells, they tend to respond. So we changed our criteria from 100 billion max to 150 billion max. So because it seemed like patients that got more did better. And we're not the only center to do this. There are a few other centers that are opening up. In fact, Mark Ferries is starting a program here at the John Wayne, which will be exciting. And we really want more centers to do this because I think it's a very effective treatment. These are from the NIH. Steve Rosenberg, where I used to work, has had wonderful results. Even tumors this big have gone away. Liver metastases have gone away. So this is very similar. In fact, that's one of the reasons I left the NIH, is because we were doing this wonderful therapy there, and no one else was doing it. And I thought, well, why am I here if we're just doing it in one center? So I went to MD Anderson to specifically set up this therapy. This is another example from the NIH of large lesions that have gone away. They tend to stay away. So this is overall what was published from the NCI experience. You can see patients, we do have some very long-term survival in some patients. And importantly, patients who have failed Yervoy, an FDA-approved drug that you'll hear about, can also respond to this. In fact, on an early look, it looked like they almost did better with the T-cells if they had had previous anti-CTLA-4. There's some scientific rationale of thinking that if you kind of boost the immune system with the ipilimumab, that maybe the T-cells work better. So I think the big question, though, is, well, someone who failed anti-PD-1 responded T-cells. And we don't quite know the answer to that. We're just treating our first patients. We have a couple responders, but we're just now trying to get that experience to know if we can salvage patients who fail anti-PD-1, which will be very important. So overall, the response rates are in the 40 to 50% from multiple centers, which compares very favorably to the current FDA-approved agents. And this has been published now by multiple groups, the NCI, MD Anderson, our group there, a group even in Israel, Sheba Israel, has treated a number of patients with T-cells and gotten that program off the ground. In the Moffitt Cancer Center in Tampa, Florida. So multiple groups now have reproduced these results. Now, so the question is how to pay for it all. Our next step is to really make this more available to patients, because we can only treat 2 patients a month. We're just now starting a method where we're going to be able to treat 4 to 5 patients a month at MD Anderson. But we've got to simplify our methods so we can treat many more patients every month. So that's one of our goals, so that all patients can potentially have this opportunity. The other is to try to get centers to open up. So we're really happy that Mark is opening up a center here for TIL therapy. Then we can do very large trials together. Once we get more centers, we're trying to help the Hutch and Seattle open up a program as well. The other question is how to pay for the cells, and because it costs $20,000 to $40,000 per patient to grow up these cells. We're trying to make that cheaper, but the FDA, we did apply for this mechanism with the Food and Drug Administration. They allow very effective therapies to to bill for cost recovery, not for a profit, but to just recover the cost. And they actually said we could do that. There's some criteria we had to send in and submit. So they actually gave MD Anderson approval to bill for this. So we haven't started doing that, but if it's an avenue for institutions who want to start this to actually pay for it and survive, and that's a way we can make this grow. So these are the centers now, and there's some other centers in Europe that are opening up. Copenhagen, one of my friends up there, Perthor Stratton, has a program, and a few other places in Europe. So it's really, overall, over 700 patients have gotten this now. Now, so our next questions are, do other therapies that you've probably heard about and you're going to hear about more help T-cell therapy? Can you put them together? It just makes sense to do. So we've done a series of studies of anti-PD-1 antibodies, something you'll hear about in a few minutes, that takes the brakes off the immune system, really highly effective drug, and Omer's been very key to some of those studies. So in the mouse, we tried the combination of anti-PD-1 plus T cells, and we're very excited about it. Here we've labeled the T cells with an enzyme that makes fireflies glow called luciferase. And so we've used that, and so we can follow the T cells after we inject them into mice. And they go to the tumor and proliferate much better if we give anti-PD-1 plus T cells. You can see it's much brighter when we look at the light detection from the luciferase compared to the control. That means that there's more T cells there. So in the end, what we want to do, in our mouse studies, we got more tumor regression when we gave the anti-PD-1 plus the T cells. So people say, oh yeah, these are mice though. You know, we're not like mice. You know, you can get anything in the mouse model, right? I hear that all the time. But you know, what are we? You guys think we're 50% like mice? Who thinks we're 50% like mice? Who thinks we're 70% like mice? Okay, I got some 70. Who thinks we're 90% like mice? You guys are smart. That is the answer. If you sequence and look at homology of our DNA, we are 90% like mice. So, you know, don't get the big head, you know? And we've developed plenty of things in mice that work in people. These same models is exactly what Yervoy was developed in. Jim Allison, who now works at MD Anderson, developed Yervoy in the B16 melanoma model. And that's how he decided that anti-CTLA-4 was something that we should take to patients. And so it got FDA approved. So these models really help. Now, not everything is going to translate, so it's important to do clinical trials, of course, but mouse models often indicate what's going to work in people. So the next question is, you know, you've heard a lot about BRAF inhibitors, vemurafenib, Zelboraf, and the GSK drug is coming along. So we wanted to see if those two in combination with T cells would work. So we looked at, we had to get a tumor with a BRAF mutation, and when we added the BRAF inhibitor plus the T cells, we did get a better response. And I'm sorry that looks so bad, but we also looked at the trafficking with the firefly luciferase, and their T cells get to the tumor better. We think it's because they block a protein called VEGF, but the bottom line is we think they work together. So we just got FDA approval to add a cohort to our study, so that if patients are on a BRAF inhibitor and then they fail, they're allowed to continue on the BRAF inhibitor, and then we add the T cells on top of that. Because the BRAF inhibitor works great, as you'll hear, but the recurrences are frequent, and so now hopefully we'll have a backup plan with this. So the bottom line is that we think that by inhibiting the BRAF inhibitor, by adding anti-PD-1, by adding T cells, putting all these things together, we can get a better anti-tumor response, and that is our goal. Now, our next set of trials are coming up are going to be to put unique genes into the T cells. So there are a lot of ways we can manipulate the T cells to try to get them to recognize different things, to try to get them to move better to the tumor site. So that's another study that we're trying to start very soon. This is something that I did with Zelig Eshar from Israel 20 years ago. It shows how long it takes things to actually come to the clinic. We started this in our mouse models 20 years, one of my first projects in 1993. And that was to say, you know, look, we can't grow TIL cells on every patient. It's about 60% of patients can grow TIL cells. But so what do we do for everybody else? Well, one thing to do would be take the blood and just put a gene in there and redirect the cells to teach the T cells in the blood to go after the tumor. So that's what we did. We took antibodies and we made fusions of antibodies with signaling genes called chimeric antigen receptors, and we started putting those into T cells. So the principle is that you take a T cell, you put a gene in to help it recognize the tumor, and then you reinfuse that tumor. It's actually quite a straightforward process. Back then it was really hard to do, but now the technology is so much better, it's actually quite easy to do. And so this is our first paper in describing this, and this is the killing of ovarian cancer. You know, no one can grow T cells against ovarian cancer. We actually took T cells, modified them, so that they could then kill the ovarian cancer cells with this gene. So that, I think, can be applied to melanoma, so that that's one of the opportunities. If we can grow the TIL cells, great, that's about 60% of the patients, but for the other 40%, it's possible that we can start a study to take the blood and then put the gene in to help redirect those cells against the melanoma and then reinfuse them. And I know that a number of groups are making receptors that might work against melanoma. The other thing you can do is immune cells travel around throughout the body by detecting breadcrumbs, called chemokines. That's how they know where to go. That's how they can travel. And the chemokine receptor is this. We have a fancy name. We call those 7 transmembrane receptors. That's because they go through the membrane 7 times. 1, 2, 3, 4, 5, 6, 7. That's just a fancy name for it. But that's what detects the breadcrumbs that helps the immune cells travel around through the body, just like Hansel and Gretel. And the problem, we give hundreds of billions of T cells, you know, but oftentimes they don't go to the tumor. They get stuck in the lung and the liver and the spleen, and very small percentage. It still works, but a small percentage. If we can make that more efficient, we could actually improve the therapy a lot. This is indium-labeled T cells, and we gave to patients that we looked out after several times, and you can see that it's very inefficient going to the tumor. And we know that the breadcrumbs, the chemokines, are made by the tumor. The tumors make them because it helps the tumor survive and it helps them make blood vessels. That's why the tumors are making these chemokines. And so the issue is the tumors are making these chemokines so they can grow better and they can grow blood vessels. But the problem is our T cells don't have the receptor to recognize these breadcrumbs, these chemokines. So one goal is to put these chemokine receptors into the T cells to get them to move better to the tumor. And we worked on this for many years. We finally got it working, and that we can see there's, again, the light model with the luciferase made by the T cells. You can see more T cells if we put this chemokine receptor in the T cells compared to the control, more T cells going to the tumor site. And again, we got a better anti-tumor response and better survival in our mouse studies when we put that chemokine receptor in. So we are actually ready now to do a clinical trial. We're going to start in the next couple of months where we're going to give some cells now. We have to escalate it in a phase 1 trial, but we're going to give some T cells that have this breadcrumb receptor essentially to try to get them to seek out and find the tumor. And so hopefully we can get out of the 100 billion cells we give, more of them will actually get to the battlefield where they're needed. And so that's one of the ways we're trying to improve T-cell therapy. We're also putting in other genes. One of them, you know, the tumor's also smart. They make, if the T cells are Superman, the tumors make kryptonite, you know? They're smart. Everyone knows kryptonite and Superman. Yeah, and so we're putting in a receptor called the TGF-beta dominant negative receptor. Don't worry about that name. But what it is, though, is it's like an anti-kryptonite gene that will help the T cells not be susceptible to all the kryptonite that the tumor makes. And so that's another way that we're trying, and that should start in the next couple of months, too. So I know we've had so far a tissue type restriction on some of our trials. You had to be HLA-A2, but once these other trials open up in the next couple months, there won't be any restriction on the tissue type that we'll be able to put patients on either one of those studies. The one that puts the breadcrumb receptor on the chemokine receptor, and the other one that puts the anti-kryptonite gene into the T cells. So we're trying to make the therapy better just incrementally. So the bottom line with all of this, patients can achieve durable responses from T-cell therapy with metastatic melanoma. We have lots of patients now that came, even a kid I can think about from high school. He came and he woke up one morning, he couldn't see out of one side. He had a brain met. We took that out. He kept getting brain mets. We did gamma knife, and we finally gave him T cells. And now he graduated from college. He's almost graduated from University of Georgia now. He's just disease-free. We have lots of patients like that. So we know this can cause durable survival in patients. We just have to figure out how to get more patients this therapy. Patients who fail standard therapies, including ipilimumab or Yervoy, can respond to T-cell therapy. Our next question is to see if anti-PD-1 failure patients can respond. We need to define who responds and who doesn't, and how can we make the responses better. An increasing number of institutions are able to administer this therapy, and this will only increase as we continue to simplify the methodologies. For example, if we can find the right cells to give, we may be able to give 10 billion instead of 100 billion, and that would make it much cheaper and easier for people to give. So we're trying to find the right cells, and that might also make it cheaper and easier to distribute. And finally, there are many ways to improve the T-cell therapy. I showed you a bunch of those that we want to do, adding anti-PD-1 therapy plus T-cells, adding the BRAF inhibitor plus T-cells, or putting these genes in to jazz up the T-cells. And so they're all very actionable right now. It's not science fiction. It's very straightforward to do these things, and we're going to push forward to try to make the therapy better yet. And so I want to thank people from all over the country in our institution. It really takes a massive army of data coordinators, research nurses, nurse practitioners, physicians, surgeons, pathologists, everybody working together with a common goal, and that's to keep patients alive, to make patients what we call the 10-year club. That's our goal. We're not after trying to increase survival by 4 months. We're after getting patients 10 years and beyond, and that's what everyone's after, and so that's why the team works very hard. We have people who take the tumor into the lab. For some reason, the surgeries always happen Friday afternoons at 4 o'clock, but they'll come, and they know there's a patient on the other end of that. They'll be there in the lab till midnight processing that tumor, and they do an excellent job. So I really appreciate the team of people that we have. Right. Thank you very much.